Hello, I'm Adrian Gowdy, and in this lecture we're going to talk about the common biliary pathology that you may come across when performing ultrasounds. So the first thing we're going to discuss are gallstones. Now, the ultrasonic features of gallstones are fairly straightforward. A stone is an echogenic mass, and it will be associated with posterior acoustic shadowing. The stone itself may be mobile, or it may be impacted, particularly in the neck, and we see this in both biliary colic and cholecystitis. Ultrasound is very sensitive for gallstones and has a reported sensitivity of greater than 95%, and in fact this is better than CT, because stones may be isodense with bile and so may not be apparent at all on CT. So this is the typical image that we may see in a patient with gallstones. Here we have an echogenic mass with posterior shadowing. Here another echogenic mass with posterior shadowing. There's possibly another mass here. This may be the edge of a stone, or it may be a little bit of sludge, and we can determine that by sweeping through the gallbladder in both planes fully to explore this a little bit further. If we look, here is another example. Here we have gallbladder. Here we've got echogenic mass, and there's definitely some shadowing here. This again probably represents other stones, and as we sweep through we'll probably pick up the shadowing from those stones as the beam is centered directly onto the stone. So what are the pitfalls when scanning gallstones? Well, firstly, a small stone may not shadow. If the stone is small enough that most of the energy from that ultrasound impulse will still get past it and be reflected back, then you won't get the shadowing. And so this is particularly seen if the stone is very small, or if it is not in the center of the beam, and so most of the energy goes down past the side of the stone. So it's always important when scanning for stones to try and line up right over the top of the stone so as to give yourself the best opportunity to detect any shadowing. Some of the machine settings, such as compound imaging, and this is now standard on most ultrasound machines, will also reduce the amount of shadowing that you'll see. And in these cases, if you're uncertain, sometimes it may be worth turning off the compound imaging to determine if there truly is shadowing there. When we're looking through the gallbladder, we must scan right the way down through the neck, because this is where stones are often missed. But when you do so, you have to make sure that any shadowing that you see is actually from a stone, and it's not edge shadowing due to a fold of where the neck and the body meet, or from the spiral valves of Heister. And these can both mimic stones, causing shadowing deep in the neck and the bright echogenic surface of either the fold or the spiral valve. And so if you're unsure, it's worthwhile looking from another window just to try and distinguish between these possibilities. Finally, because of beam thickness and beam width artifact, reflections from duodenal gas, which often sits right next to the gallbladder, can appear to arise from actually inside the gallbladder. And the best way to distinguish these is to try and optimize your imaging with your focal point so that you get as crisp and as clean an image as possible, and with the narrowest beam at that point, and to look from different windows just to determine where exactly the edge of the gallbladder is, to make sure that any reflections that you're seeing actually do arise from inside the gallbladder itself. And again, sometimes it can be very difficult, particularly if you have a small layer of very small stones, to be certain whether the reflections and shadowing from there arise from inside the gallbladder or from gas that's just outside in the duodenum adjacent. Now, one of the things, and we mentioned this in the previous talk, is that distinguishing between a contracted gallbladder that's full of stones and duodenal air can be very, very difficult. What we look for is we look for the wall of the gallbladder, and usually there's a very fine thin layer of bile, and then we will see the bright echo of the stone and the shadow behind it. And one of the things we look is at what that shadow looks like. Is it a clean shadow, which is what we get from stones, or is it the dirty shadowing that we tend to get from air, which is a mixture of both shadowing and also reverberation artifact. Finally, the other thing you can use to help distinguish them is if you watch for long enough, you may see the gas move as a wave of peristalsis comes through. Stones, of course, will not demonstrate this. Sometimes you can give the patient some water to drink. We usually get them to drink through a straw so they don't swallow air, and then you can wait and watch as that liquid comes down through the stomach, through the pylorus, and into the duodenum. But that's often difficult. If the patient's in pain particularly, then they may have delayed gastric emptying, so it's not actually as useful as it may sound. Less commonly, you may see a porcelain gallbladder. These are uncommon, and in this case the wall itself becomes calcified, so that the calcification isn't inside the lumen, it's actually in the wall. Similarly, and also uncommon, sometimes you may see gas in the gallbladder wall, and this is a sign of emphysematous cholecystitis. And when severe, this can blur and make the whole outline of the gallbladder difficult to distinguish. So it's uncommon, but it is an important condition because it's associated with a high mortality. If bile is sitting in the gallbladder for a while, it becomes concentrated. That's the function of the gallbladder, and as it does so, it can become echogenic, and this is referred to as sludge. This will usually be dependent and will cause a layer across the gallbladder, and is commonly seen in anyone who's been fasting. But sometimes the sludge may actually fall into a ball, and this is sometimes known as tumefactive sludge, and it will cause an echogenic mass, but it does not shadow. If you do see shadowing from inside of sludge, it means it's actually a mixture of stones and sludge. Now, the stones may be very small, but if there is shadowing, it's not simple sludge. Similar to sludge in appearance, although it's not mobile, are polyps. These are echogenic masses, and they are non-mobile. They do not shadow. Small polyps are common and are virtually always cholesterol polyps, and they do not need follow-up. Different protocols have different cut-offs as to what size polyp may need follow-up, but certainly a large polyp or a sessile polyp, or one that's got colour flow in it, is suspicious, because some of these may be neoplastic polyps and need either follow-up or removal to prevent them from developing into cholangiocarcinoma. However, most polyps that you'll see will only be 2 or 3 millimeters in size, and these are cholesterol, almost invariably cholesterol polyps, and so do not need follow-up. Here's an example of a gallbladder polyp. This is a simple polyp. It was 4 millimeters. It was non-mobile. Now, one of the things we have to remember when we see gallstones is that they're actually quite common within the community, and so they may be an incidental finding. And so you have to be careful when considering your diagnosis as to, was the gallstone the cause of the problem, or was it just an incidental finding, and then in fact what you've seen is one of the common asymptomatic gallstones. And a gallstone, particularly that is mobile, is probably asymptomatic if the patient still has pain at that point, because in biliary colic the stone is generally impacted. So moving on, what happens if there is, say, an impacted stone, but now it's starting to become, the gallbladder is starting to become inflamed? Well, in that situation we now have cholecystitis. And the ultrasound features of cholecystitis are a thickened gallbladder wall, a sonographic Murphy sign. There is generally a stone that is impacted, usually down in the neck. The exception to this is, of course, Acalculous Cholecystitis. There is pericholecystic fluid, and this is seen usually between the gallbladder and the liver, in the bed of the gallbladder. The wall may be hyperemic if you look with Doppler, although usually this doesn't tend to add much. The gallbladder itself is usually distended, and so it looks full and tense, although in the setting of chronic cholecystitis, where the gallbladder wall is thickened and fibrotic, it may not be able to distend. Overall, as we've mentioned, ultrasound is good for diagnosing cholecystitis and has a sensitivity of 85% and a specificity of 95%. So this is the classic sort of finding that you'll see. Here we have the gallbladder. We have a grossly thickened wall measuring 13 millimeters, and there's looks like a little layer of edema within that wall. There's possibly a very thin line of pericholecystic fluid here, although it's difficult to be certain on this image. And here we have a multitude of stones. This stone that we're focusing on is demonstrating some shadowing here. And in this patient, when we put the probe on the gallbladder and pressed, it elucidated pain, and that was the most painful point to press on for the patient, and that's what's referred to as a sonographic Murphy sign. Now, as well as diagnosing cholecystitis, ultrasound can be used to detect some of the complications. You may see sloughing of the wall due to gangrene, and gangrenous cholecystitis obviously has a much higher morbidity and mortality. You may see focal perforation and local abscess formation. And as we've mentioned before, rarely you may see emphysematous cholecystitis. Now, generally these things are probably going to be beyond the scope of the beginner, but you may see them. One thing I will mention is that because you may well have a layer of sludge in the gallbladder due to stasis, that distinguishing that from the wall that has sloughed off can be very difficult, and so I'd be cautious in overdiagnosing gangrenous cholecystitis when you begin scanning. So here is another example of cholecystitis. Here we have multiple stones within the gallbladder. We have a thickened gallbladder wall. We have a little bit of fluid in the pericholecystic space. The patient was febrile and was tender. This was a man, he was an elderly man, and he actually presented in septic shock. And when we looked at the fundus of the gallbladder, we see numerous stones along here, but we also see this little fluid collection sitting at the fundus, and this was due to a localized perforation and abscess formation there. So what are the pitfalls of ultrasound for cholecystitis? Well, probably the most important thing to remember is that there are actually many causes of gallbladder wall thickening apart from cholecystitis. This is a list of some of the more common ones, but there are actually even more than this. Patients with cirrhosis and ascites, the gallbladder wall will often look thick. Any generalized edematous state, such as congestive cardiac failure or in a low protein state from, say, nephrotic syndrome, will cause generalized edema, and that can be reflected in edema of the gallbladder wall. Hepatitis will often be associated with gallbladder wall thickening, and in fact the degree of thickening can be used as a marker of the severity of the hepatitis sometimes. If you have inflammation adjacent to the gallbladder, such as in pancreatitis or colitis, then the gallbladder wall can also become inflamed and thicken. HIV infection is associated with wall thickening. And then, as well as the diffuse thickening, you can get diseases that usually cause focal thickening, although both of these can also cause diffuse thickening. The first is adenomyomatosis, and that is where you get localized hypertrophy of the walls and the formation of Aschoff-Rokitansky sinuses, which often will then fill with cholesterol crystals. And as a result, you get bright little foci with ring-down artifacts in those areas. And adenomyomatosis, as I said, is usually focal, but it can actually be generalized sometimes. The more sinister problem is cholangiocarcinoma, and again that usually causes a focal thickening of the gallbladder wall, although as it spreads and becomes more severe it can be more diffuse. Don't forget that the normal gallbladder wall is 3 millimeters. So here is an example of a patient who had hepatitis, and we can see here that this gallbladder wall is grossly thickened and looks edematous, and there's possibly some fluid planes within the gallbladder wall, and it's measuring 16 millimeters. But as I said, this is a patient with hepatitis. There were no stones, and this was not cholecystitis. Acalculous cholecystitis is a very difficult diagnosis to make with certainty on ultrasound. It's generally said that 5 to 10% of patients with cholecystitis will have acalculous cholecystitis, and these patients usually have comorbidities and are generally very unwell. It has all the features of cholecystitis, but with no stones. Due to stasis, sludge is often present, and as we've mentioned, it's often difficult to distinguish from the other causes of gallbladder wall thickening. And a patient who has the comorbidities to cause some of those causes of gallbladder wall thickening are often the ones who are at risk of having acalculous cholecystitis. The other difficulty is this is a condition that often occurs in patients in the intensive care setting because they are so unwell, and so they may well not be able to tell you where their focal tenderness is. And so the diagnosis overall relies on correlating the overall clinical picture as well as all the investigations. Now here is an example of a patient who had gallbladder wall thickening, tenderness over the gallbladder. They had raised inflammatory markers and were septic, but there was no stones. We can see here is the sludge that's formed in the dependent part of the gallbladder, which we also see here transverse. And in the end it was felt that this was acalculous cholecystitis. So, moving on to bile duct obstruction. While ultrasound is very good for this, it has a sensitivity of 90% and a specificity of 95%. In addition, it can be used to determine the level of obstruction by looking at whether the intrahepatic ducts are dilated alone or whether there's also dilation of the common bile duct, and if so, is it just the proximal or the entire common bile duct. However, even though we may well determine the level of obstruction, we often cannot determine exactly what the cause of the obstruction is, because we may well not be able to see the entire common bile duct due to shadowing from overlying duodenal gas or stomach gas that can obscure the distal CBD and also the head of the pancreas. So the first thing we'll usually look at is the common bile duct and the size. Now, it's useful to know the size of the common bile duct, but you also have to remember that it varies between people, and so it's not a distinct cut-off as we may sometimes portray it as. The duct often dilates slightly as it passes into the free edge of the lesser omentum, and it will usually taper as it enters into the head of the pancreas. It's usually reported that it increases in size with age, and many people believe that it increases post-cholecystectomy, although the literature is actually divided as to whether this occurs or not. The other thing to remember is that if a patient has had an episode of obstruction and the duct is dilated, in 25% of cases it will not return to normal. So 75% of the time it does return back to normal, but in 1 in 4 cases it doesn't, even though the obstruction is relieved. So in general, what we use as a cutoff is generally 60 millimeters in patients up to the age of 60, and then 1 millimeter per decade after that. Often people will then add another 1 millimeter if the patient has had a cholecystectomy. If the patient's known to previously have had bile duct obstruction, then the best thing to do is to try and find some more recent imaging and see what the duct was at that time, and if it has dilated beyond that, then you can infer that there is new acute obstruction. So this is the sort of image that we'll look at. Here we've put the colour box on to show this is the portal vein. Here we have the hepatic artery, and here anterior to both is the common bile duct in the porta hepatis, and here it measures 8.5 millimeters, measuring the internal lumen. If we follow and track that bile duct down, what we can see is as it gets nearer the head of the pancreas, it actually dilates more, and then in the distal CBD, what we saw was a stone in this case. Now, as well as looking at the common bile duct for obstruction, we also look at the intrahepatic ducts for dilation. Now, it's generally said that the normal bile ducts can be difficult to see inside the liver parenchyma, and that's certainly true for the distal ducts and in patients who may not be easy to scan. However, with modern machines, in patients who are thin and you get very nice images, you may actually see the bile ducts as they travel out to the periphery. The way we then decide whether they're obstructed is we can look at the size, and the main right and left bile duct should be less than 2 millimeters, and the duct should always be smaller than the accompanying vessels. And so when you do get dilation, this is often described as the double barrel sign, because instead of one wide tubular structure being the vessel and a very narrow accompanying bile duct, you'll have two that are about the same size. You can also put colour imaging on to distinguish which one is the vessel and which one is the bile duct. The ducts also tend to have a more brighter and echogenic edge to them, but until you get used to the appearance, often putting the colour flow on is the best way to tell. In general, dilation is more commonly seen nearer the porta hepatis. And so this is the sort of image that we may see. Here we've got a large number of tubular structures running through. This is in the left lobe of the liver, and when we put the colour on, we can distinguish which ones are due to vessels and which ones are actually the bile ducts, because they're not taking up any colour flow. What are the pitfalls? Well, first of all, you can get obstruction without dilation. This occurs particularly early on and can also occur if there's intermittent obstruction. Finally, there are some conditions where if you have fibrosis of the ducts, such as in sclerosing cholangitis, they lose their elasticity and so they are unable to dilate. Also, if you have cirrhosis of the liver parenchyma becomes more dense and so will prevent the dilation of the ducts within it. We'll go through during the course and show you more examples of all of these cases and all of these conditions so that you can try and get used to what their ultrasound appearance is like. So in conclusion, biliary ultrasound ranges from technically simple to very difficult. And when you're starting, then if you come across a patient who is difficult, then make sure you ask for some assistance. If the clinical picture matches the ultrasound picture, then most likely your diagnosis is going to be spot on. But if the clinical picture doesn't match the ultrasound image, or if you can't get the imaging you require then to make a confident diagnosis, then you should seek further assistance and get someone with more experience, or arrange a comprehensive ultrasound, or arrange other imaging as required. Thank you.